Okay, let's do the first of our two reproductive pathology lectures. As with most of the systems, especially the ones that are in ANP2, and especially the ones toward the end of ANP2, I'm going to do a brief overview of regular anatomy and physiology of the reproductive system, because some of you might not have had it or will be having it toward the end of the semester, and I want to make sure you know what we're talking about here. So development of the reproductive system happens in utero very early in fetal development. If you are designed to be a male fetus, the genetic Y factor causes you to your primordial gonads to become testes, and they start secreting testosterone. And it's that process of secreting testosterone that is required for your body to develop into that of a male. In the absence of testosterone, or if you're unable to respond normally to testosterone, you will have a female phenotype. You'll turn out looking like a female even if genetically you're a male. Males need testosterone, females estrogen, follicle stimulating hormone and luteinizing hormone come from the pituitary. They will stimulate both sets of gonads once they develop into whatever they're developing into. Follicle stimulating hormone stimulates testes to make sperm, and it stimulates female ovaries to produce mature eggs. From their primordial eggs they have in there, they select a few every month. One of them becomes dominant and matures into the Graafian follicle, which is the main egg that is going to be produced that month. Luteinizing hormone causes you to make hormones. And so it causes you to make testosterone and dihydro in the male, and the female it causes you to make estrogens. Start out with undifferentiated gonads and both sets of tubes. These ones out here could become fallopian tubes. These ones in here can become the vas deferens. And they're the ones that are actually attached. So in the presence of testosterone, these guys mature, these go away, you produce an inhibitory hormone that causes these to go away. These become vas deferens, they're attached to the testes will then descend into the scrotum. On the female, if you don't have testosterone, these Wolffian ducts, they're called, that are the male progenitor tubes, disappear. The female ones develop, the fallopian tubes or uterine tubes, as they're called a little bit more now. They're not actually attached to the ovaries. Instead, they're close by. When ovulation occurs, they create a little vacuum that pulls them in to the end of the fallopian tube and goes down here to become fertilized about here and then implant in the uterus. The external genitalia, we saw this before, starts out the same, and the hole closes in the middle if you're going to become a male, stays open in the middle, and becomes the vaginal opening in a female. Puberty is described at the point where suddenly a maturation of the gonads causes an increase in androgens and estrogens, which cause you to suddenly develop, rather suddenly, develop dramatically into sexual maturation. It causes the growth of body hair, increase in musculature. For girls, it's a little ahead of boys. At 100 years ago, puberty was about 16 years old. Now it's around 12 or 13. It's getting younger and younger and younger. And girls tend to mature a year or two before boys do. thelarchy. Archy is like in archaeology, it means the first study of the first. Archaeology. So thelarchy is the breast development first starting. Menarche is the first menses, the first menstrual period. With the male, the larynx changes shape, forms the Adam's apple, and lengthens the vocal cords, so the voice starts lowering, and the sperm start maturing and being ready for reproduction. Adrenarche, this is when you first start making adrenal steroids. If you remember, the adrenal cortex makes cortisol and aldosterone, but it also makes small amounts of testosterone, dihydrotestosterone, estrogens, and that increases at that time too. That helps boost the conversion to a mature person. Gonadostat sensitivity cuts back on the negative feedback for LH and FSH, and actually for a short time there's a positive feedback where the more you make, the outcome causes you to make even more so that you can push the maturation of the ovaries and testes. So, increase in hypothalamic output of gonadotropin-releasing hormones, causing the anterior pituitary to produce more LH and FSH, or gonadotropins. The ovaries and testes start increasing their outputs of estrogens and testosterone. Once mature, the female genitalia, the mons pubis, the labia majora minora, clitoris, the vaginal opening, the perineum is in here, the urethra, actually the clitoris is up here, the urethra is here, urethra very close to the vagina, also relatively close to the anal opening. It's why it's so easy to get vaginal and urinary tract infections. Internally, the ovaries remain up in the upper part of the pelvic cavity above the uterus and the bladder. Bladder has the urethral opening, the uterus, the cervix of the uterus is the opening, the vaginal canal here, the vaginal opening very close to the urethra. Fallopian tubes or uterine tubes close to the ovary, and they're connected by a suspensory ligament that holds them in the right position toward each other. You also have an area right in here called a cul-de-sac. It's a pouch that has a tendency to have fluids in it that can be measured. Also, you can have herniations between the uterus or the anus or the bladder that can affect this cul-de-sac or space between the uterus and bladder. The uterus itself, normally positioned, at a sort of an angle to the vagina, but it can be low, it can be high, it can be bent. Midline uterus is kind of going straight up and down. Anteverted swings toward the front. Retroverted swings toward the back. And flexed means crooked. Anteflexed, retroflexed. Modest amounts of disposition are not important. Major amounts could be. Here we have the ovary held in place by the ovarian ligament. And here we have a suspensory ligament that holds it to the uterine or fallopian tube. The fimbriae of the fallopian tube, when you have ovulation, will help pull the egg into here. It starts moving slowly through here. At the same time, sperm are coming this way. Typically, fertilization takes place in the first 24 hours, about here. If it takes place way too early, it may grow too big, and you might get lodged and have an ectopic pregnancy. If it is fertilized too late, the endometrium won't be ready. It'll come in here and there's nothing to attach to, and it will probably die. Each month you start off with a small group of ova, and they start developing, and one of them predominates, takes all the nutrients, grows into the primary follicle, the Graafian follicle. The Graafian follicle is surrounded by a group of secretory cells called the corpus luteum. And at the time of ovulation, the egg comes out, and the rest of this stays for several days, making hormones, especially progesterone and LH, that are required for the maintenance of the endometrium until the egg can get there and implant. After a few days, it starts falling apart and it dies out. And if you haven't implanted by then and started making new hormones from the placenta, then the fetus can't be viable. Main female sex hormones are your estrogens. Actually, they're made from testosterone. Testosterone starts everything. You make testosterone. If you're a female, you convert it into your estrogens, or most of it. You keep some. With a male, you keep it mostly as testosterone and convert some of it into dihydrotestosterone instead of converting it into estrogens. And that's the way you differentiate your hormones. Estradiol is your main estrogen. Estrone and estriol are in smaller amounts. Progesterone you make in large amounts, especially during the part of the menstrual cycle where you have to build the endometrium and ready it for implantation. You have more progesterone than estrogens. And then at the time of menstruation, they swap places. Once the progesterone goes down compared to estrogen, you menstruate, and everything breaks apart and comes out. The same thing happens with childbirth. During pregnancy, progesterone stays high. When it's time for childbirth, you change places, and childbirth takes place. Menstrual cycle, menarche, first menses, the first period that happens at the very onset of puberty. Menopause is the end of your menstrual cycle, lifetime, and you stop doing menstrual cycles. We have menstruation, where the previous material from the endometrium is sloughed out. Then you have a follicular phase where that follicle is starting to develop in the ovary. The luteal phase where the corpus luteum is secreting its hormones after you ovulate. And then the ischemic phase, which starts menstruation again as you cut off blood flow to that new endometrium and it sloughs off. You have a rise in estrogen temporarily before ovulation. It induces a LH spike. The LH spike causes ovulation. LH spike causes ovulation. At that point, progesterone goes up compared to estrogens. And you build your endometrium, build it, build it, build it, and then progesterone drops and menses begins. Progesterone causes your temperature to go up slightly. That's why women can tell if they've ovulated. Their temperature goes up half a degree, and they can tell that it might be time to get hubby home if they're trying to have a kid. Other reproductive glands for the female involve lactation, involve milk production, and the breast contains these lobules. This is a lobule. It's filled with alveoli. These look like alveoli in the lungs, but they're filled with fluid. And they also look somewhat like sweat glands, which have a lot of little balls of secretory cells on a common duct. And that's actually what they are. Prolactin causes these to develop from simple sweat-type glands into these bigger, more prolific glands that will secrete also proteins and fats as well as fluids into the milk duct. The pore in the middle of the nipple, areola is around the outside. And the breast it produces a lot of fluid, so excess fluid is taken off by a very extensive lymphatic network. And each part of the breast the lymphatic vessels lead into what's called a sentinel node. The sentinel, in other words, it's standing by, it's watching out for that part of the breast. If you think you have breast cancer and it may have metastasized and you're right here, you look at these guys. Those are the sentinel nodes for this part of the breast. If they don't have any cancer in them, then it hasn't gone any farther than that. Over here, you'd be looking at a couple over here. You don't have to take all these guys out if these guys don't show any cancer cells. Male reproductive system. The penis, corpus spongiosum, this is the spongy tissue it's called. The corpus cavernosum is on the top, that is largely responsible for erections. The glans penis is the head. The foreskin is also called the prepuce. The testis, which contains seminiferous tubules that make the sperm, mature the sperm. It's stored in the epididymis. It's released into the vas deferens, which goes all the way around here, comes through the seminal vesicle, which adds some more semen fluid to it. Then it goes through part of the prostate, joins the urethra, and then exits through the urethra. Scrotum, the bag holding the testes. Seminiferous tubules, epididymis, and vas deferens. Development starts, as you saw, with the closure of what could have been the vaginal opening and the lengthening so that the hole comes out the end. The vaginal process disappears. The inguinal canal along here takes that primordial testis and allows it later to descend down into the scrotum, if it does. Occasionally it doesn't descend and they have to induce it to go down. Usually that happens around the time of birth. The inguinal canal then is this tube-like place where the testes can descend, and it remains a weak spot that can cause hernias later in life. Erectile apparatus. The spongy tissue fills with blood and causes the erection. It's a hydraulic process, primarily in the cavernosum, which has its own blood vessel to pump it up and then close and let it drain when the erection is no longer needed. Parasympathetic nervous system stimulates erections. Sympathetic is ejaculation. So if you damage parasympathetic nerves, you're likely to have erectile dysfunction. Some of your drugs, erectile dysfunction drugs, are parasympathetic stimulators, some of which cause you to make nitric oxide, which is a vasodilator to allow more blood to go through. External genitalia. Here comes the urethra from the bladder. It goes right through the middle of the prostate gland. So if you get BPH, it can smash it and make it hard to pee. Along in here, the ejaculatory duct enters and moves part way through the prostate too, so that some extra fluid from the prostate can be added. Cowper glands add lubricant oils to make things slippery and move easier. Spermatogenesis starts with lots and lots and lots of primordial cells that mature, split, become spermatids, which are still attached here, attached to each other, but are starting to grow the flagella. And then when they are released, they become active or mature sperm cells. Sperm cell itself, mitochondria, a lot of mitochondria in here, a lot of actin and myosin filaments that allow the flagella to whip back and forth. The nuclear part or the body of the sperm contains the genetic material, 1/2 of the 23 pairs of chromosomes. So it can join with mom and wind up with 23 pairs, 46. And acrosomes at the tip, which will dissolve the egg shell and allow the sperm to inject its genetic material into the egg. Male sex hormones are primarily testosterone and dihydrotestosterone. Andro is another one that is less important, but it's still a steroid. I remember when some of the big baseball players that, they started out with arms the size of mine and wound up with arms this big. They were taking andro. Oh, we're not taking a steroid. They were. It just hadn't been banned yet. Produced in Leydig cells, they produce testosterone, converts to dihydrotestosterone. Causes sexual differentiation. It's required for the male to become a real male. And nervous, skeletal muscle, bone, red blood cells. And libido in males and females. The desire to have sex is actually produced by testosterone in both males and females. Female reproduction aging. At around age 50, anywhere from like 45 to 55, but usually pretty close to 50. Perimenopause, you stop having menstrual cycles every month. You might have them sporadically, every other month, every third month, then you'll have a couple, then you won't have one for 6 months, then you might have another one. And then menopause is when they stop altogether. At this point, you stop maintaining some of the female reproductive apparatus. The vagina can, the walls can get thin and atrophied a little bit and somewhat dry, making intercourse sometimes painful. Not always. Breast tissue is not maintained as much. Skeletal and cardiac changes. You start losing a little bit of more bone mass. Estrogens help support bone mass during your reproductive years. And your cardiovascular protection. Estrogens help keep your LDL cholesterol down, and it tends to rise some and causes women to start catching up on cardiovascular disease for the next 20 years or so. Male reproductive system, ages 2, is more gradual. Of somewhere in the 70s, the testosterone starts to droop. And as a result, you start losing a little bone mass, you lose a few red blood cells, you lose some tensile strength of the skin. The testes may start to atrophy slightly. It's usually a pretty gradual process. In some guys, it's faster than others. But there are men who father babies when they're 90. Not that it's a great idea, but they can still do it in a lot of cases. LH and FSH go up because the testosterone that was the negative feedback is gone or lower. So let's talk about now some pathology. Maturation, delayed puberty. These days, if the female hasn't started by 13 showing some secondary changes, a little bit of breast budding, a little bit of pubic hair and so forth, then it's a delayed puberty. It's not necessarily a bad thing. It could be, if it's delayed a lot longer. Secondary characteristics in boys now 14. If you haven't started anything by the time you're 14, it's delayed. 15, 16 is not a big deal. 16, 17, 18 would be considered a pretty big deal. Usually it's just a constitutional delay, just a difference. I was a late developer. I didn't develop early. And so I was kind of skinnier and less hairy than the other guys in the locker room. But I got my paybacks because by the time I was 18, I was taller than all of them. They had developed early but then stopped developing. So it's a balance. It's whatever happens to you. Only about 5% are actually caused by problems with the gonadotropins. Stimulation by the hypothalamus or release of gonadotropins by the pituitary. Precocious puberty means too early. Now that would be early. As is this, same age. Some girls by the time they're 9 have already gone through puberty and are starting to grow really fast. I'm not sure if my wife went through puberty early, but she was 5'11" by the time she was in the 5th grade. She wound up being an all-Europe basketball player, which was nice, but they were afraid she was going to be a giant. She only grew 2 more inches after that, wound up being 6'1". Before age 7 in girls, before age 9 in boys. And black girls mature earlier than white girls. So actually, you know, if you actually start maturing at age 6 or 7 as a black girl, it's not considered premature, which is kind of amazing. Earliest reported girl gave birth at 5 years, 7 months, and 21 days. That's early. Hormones affect everything to do with reproduction. This hormone goes up, it makes you ovulate. This one goes up, it makes you develop the endometrium. This one goes up and it makes you menstruate. This one goes up, it makes you start developing breast milk, and this one makes you release breast milk. So it's all hormonal changes. And because of that, changes in hormonal output can result in malfunction of the reproductive system in both men and women, but more often women. Dysmenorrhea means painful or difficult menstrual cycles. Some women have a terrible time each month with menstruation. Others barely notice it. But a lot of times it's an imbalance, maybe abnormal amounts of progesterones. Secondary, you can have pain because you've had an injury, you have scarring from a sexually transmitted infection sometime in the past or some other kind of infection. Endometriosis, which grows excess tissue in the wrong places. And so it's not a problem with the reproductive system itself or your hormones, it's a structural problem more. Amenorrhea means lack of menstruation. A few things can cause that. Primary amenorrhea means there's a problem with your gonadotropins. You're not producing FSH and LH, or you're not producing estrogens or progesterones as you should, and therefore the development and sloughing of the endometrium is absent. Secondary amenorrhea is caused by something else. Morbid obesity, anorexia nervosa, being way too heavy, way too light. Excessive exercise. It's not uncommon for Olympic female athletes to stop menstruating as they train ridiculously hard for and during the Olympics. Dramatic weight loss, anorexia. A lot of times anorexia nervosa and excessive exercise kind of go hand in hand to produce amenorrhea. Uterine bleeding during or between menstrual cycles. You're supposed to bleed some. It's actually the breaking off of the endometrium and the sloughing off of that material. It can be very scanty, especially if you're on birth control pills that change your hormonal balance some. So you can bleed way too much or way too little. Menorrhagia, like hemorrhage, HHAG, that's blood flow. Menstrual irregularity. Your menstrual cycle is short one time and long the next time and may miss a month. This is probably going to be hormonal. It may be due to taking birth control pills, or it may just be that your hormonal balance is not regular. Dysfunctional uterine bleeding, very painful or between periods, called menorrhagia or metromenorrhagia. Polycystic ovarian syndrome is cysts in the ovaries, and it as it says, leading cause of infertility in women in the United States. It's caused, or at least exacerbated, by hormonal levels that are wrong, too much androgen production, hyperandrogenism. So you might have maybe becoming slightly hirsute, hair growing where it's not supposed to or something. Hyperinsulin, the opposite of diabetes if you're making too much insulin. Hypertension, dyslipidemia, your triglycerides and cholesterols are way out of whack. All of those are, they cause follicles to develop improperly, and these follicles that were going to become eggs or something just leave a cyst, leave a hole there. Hyperinsulin, insulin resistance. Too disordered or improper amounts of your gonadotropins. Lack of the ability to ovulate, so that ovum that was supposed to leave, allow the corpus luteum to die off, stays in there and can maybe form a cyst. Too much testosterone, polycystic ovaries. PMS. Almost every woman experiences some degree of premenstrual syndrome as all of the hormone levels suddenly reverse, so that you can ovulate and you can do this and you can do what you're supposed to do. You can slough off. So PMS is a hormonal switch that causes a certain amount of agitation or depression or just feeling bad about things. Sometimes it's bad enough to cause problems in relationships or their ability to actually perform their tasks that they would like to. If it really gets bad, it's called PMDD, dysphoric disorder, which is profound. And the person may, it's almost like having a migraine or something. The person may have to vanish for a day or so in trying to get over this so they can get back to their normal self. PID, pelvic inflammatory disease, is seriously, not lethal exactly, but it can cause infertility. It's caused by infection. The fallopian tubes, salpingo is the medical term for a fallopian tube. Salpingitis, then, is the fallopian tube inflammation. Oophoro is egg, ovum. Oophoritis is the ovaries. The ovaries. STDs, or sexually transmitted infections, may move from the kind of external or genitalia or vagina into the uterus and up the fallopian tubes. A variety of infections are possible. And the use of tampons, which doesn't allow as much of a free flow and stuff, have sometimes been implicated in pelvic inflammatory disease. When chronic, here the fallopian tube is completely distended and swollen and inflamed, and you develop, they call them guitar string lesions or adhesions that develop between the ovaries and the other parts of the reproductive system. Pyosalpinx means that it's filled with pus. So the infection is bad enough that your white blood cells are dying in there and filling it up with pus. Infertility, if it's not treated quickly enough. Vaginitis is pretty much a infection that's like a urinary tract infection, except it's up the vaginal canal, and sometimes it's sexually transmitted. So chlamydia or gonorrhea or something like that can cause vaginitis. So can other types of infections from perhaps poor hygiene. Candida albicans, which can grow in there, as it causes candidiasis and thrush and things like that in the mouth, and can cause inflammations and infections there too. Your vagina is supposed to be somewhat acidic. That helps protect against fungal infections and some bacteria. And for that reason, douching has become a lot less popular because it flushed out some of the natural protections that women had. Acidophilus, that's one of these, yogurt and milk with acidophilus in it. And normal flora, you're supposed to have the normal amount of your own bacteria that help fight off the bad guys. Overuse of antibiotics, it can kill off your normal flora and let things like yeast and fungal infections grow. Vulvitis, if it's on the outside. Sometimes this is an infection, that maybe it even started in the vagina and worked its way outward. Other times, it's an inflammation due to a contact dermatitis type thing, where soaps, laundry detergents, perfume toilet paper. Cervicitis is inflammation of the cervix. And if it's mucopurulent, mucus purulent means pus. So mucopurulent means there's an infection that's causing the white blood cells to die and form pus in that area. Bartholin glands on just inside and on the sides of the vaginal opening are lubricating glands, kind of like the glands that males have too that are farther up. Bartholin glands provide vaginal lubricants, and they can become inflamed or infected as well. Bartholinitis, it blocks it off. It inflames and blocks off the ducts so the gland swells up. Pelvic relaxation, it's an interesting thing to call it. To have a hernia, I guess you have to relax the tube. But it's an interesting kind of way of describing it. Bladder, urethra, rectum, vaginal opening, supported by a fascia and muscles that are supposed to hold everything in place, but they can herniate out to the side, they can herniate front and back, and they can even prolapse out through the openings. Cystocele, that would be the bladder. Rectocele, the rectum, herniating. Urethrocoele, the urethra. Cystourethrocoele, the urethra and the bladder. Enterocele, small intestine. Vaginal prolapse. It's the vagina, especially after childbirth, not being held in place and falling out of position, even out through the vaginal opening. Uterine prolapse, same thing. The vagina falling outward, the uterus can follow and actually come all the way out. They put it back in place and actually put a sling that's attached to some internal structures and hold it back in place. Bulge pushing down of the bladder, cystocele, the bladder bulging down so you can actually see it pushing out through the perineal opening here. Here's a uterine prolapse where the uterus just lost its attachments here and is falling out through the vagina. And that's the end of the first one. That lovely slide finishes up the first pathology one. We'll have one more reproductive one next time.